friends, welcome to this evening symposium. We have three learning speakers today, and the first would be Dr. Bhaskar Shukla. Everybody knows him, and he's a reputed neurologist at PSRI Hospital, and he's going to talk about pursuit of happiness in peripheral neuropathy, the scope for a holistic palliative care approach. Dr. Bhaskar Shukla, please, sir.
Thank you, sir, for the kind words. So, here I am. The topic of my discussion today is pursuit of happiness in peripheral neuropathy. And so what I am going to stress today is the role of a holistic approach. It's not only about the drug management of the neuropathic pain, it is about the holistic care. There are certain aspects of the neuropathic pain which we tend to overlook. That should not be done, because then the outcomes are not going to be optimal. So let's have a look at the global statistics. The global prevalence of neuropathic pain is estimated to be around 7%. Peripheral neuropathy is a common disorder and presents as a diagnostic and therapeutic challenge. So, as far as the Indian data is concerned, we have Indian studies which give a prevalence estimate from 5 to 2400 per 10,000 population, and the figure varies from the region, as per the region. For example, in West it's different, in South it's different. So, when we talk about peripheral neuropathy, diabetes comes to our mind first. So, basically in our practice, neuropathy means diabetic neuropathy. So, 425 million individuals worldwide have diabetes. In 2017, India had the second largest number of diabetic patients, close to 7.3 crores, and prevalence was 8.8%. And the prevalence of diabetic neuropathy in these patients varies from 18.8% to 61.9%. Besides diabetes, we have myriad causes which are less common but should not be overlooked. For example, exposure to drugs, alcohol, vasculitis, nutritional, B12 deficiency is quite common, thyroid neuropathy is common. Then we have those neuropathies associated with kidney diseases like urinary neuropathy, acute neuropathies like GB syndrome, chronic neuropathies again like CIDP, neuropathy secondary to infection like Hansen disease, paraneoplastic secondary to some primary malignancy, for example lung malignancy, which is quite common, and of course the neuropathy which is associated with chronic illnesses, some other illness in which the patient requires a prolonged hospital stay, that is critical illness neuropathy. So we are all aware about the symptoms of the peripheral neuropathic pain. So patients describe in their own words as to the quality and the character of the pain. Some people describe it as burning pain, some people describe it as if hands are crawling all over the body, or some people describe it as some abnormal thermal sensation, some people describe it as it is cold sensation, heat sensation, and associated other symptoms like numbness. So there are other different terminologies, paresthesia, dysesthesia. We will not go into the details of it. And neuropathy is not only about the sensory symptoms, it is also associated with the weakness, which can be distal, which can be proximal, and we have autonomic symptoms as well. So neuropathic pain is a common symptom of peripheral neuropathies, and it continues to be a challenge to manage, and often requires a multidisciplinary approach. 50% of patients with diabetic peripheral neuropathy they have these positive symptoms which I just described, the neuropathic pain, and the rest tend to have different other symptomatology. So pain does not exist in isolation. So pain, whenever there is a diabetic, whenever there is a neuropathic pain, it affects the physical well-being, the social well-being, the family life, the psychological well-being, etc. And these are equally important to take care of. So what is the clinical burden of peripheral neuropathy? So peripheral neuropathy is associated with dysfunction, disability, anxiety, depression. A substantial economic burden for both individuals and society. Patient report worse health-related quality of life decreases. Overall associated with poor health, and most of the available treatments have moderate efficacy and side effects. So this is the challenge. So as I said, pain does not exist in isolation. So comorbid depression is present in 31 to 88% of cases who have neuropathic pain. So this was data from the Indian Pain Clinic. So this is the biopsychosocial model of neuropathic pain. So as we can see, this diabetic neuropathy sits in the center, is at the hub of this entire model, and there are three interlocking domains. We can see biological factors, social determinants, and psychological factors. So diabetic neuropathic pain experience is affected by and affects these domains. For example, this diabetic neuropathy experience, it affects the behavioral, it is influenced by the behavioral factors such as exercise, smoking, self-care, poor sleep quality, etc. Depression, anxiety is quite commonly associated with these. And of course, access to healthcare, socio-economic status of the patient, stigma associated with these conditions. These all factors are very, very important. So, this diabetic neuropathy, neuropathy in general and diabetic neuropathy in particular, it affects the, impacts the quality of life very negatively. So as I said, the psychological problems are often overlooked and untreated. The neuropathy can be associated with postal instability, which is often overlooked and undertreated. And thus we need, besides the traditional approaches, we need evidence-based psychological interventions, we need guidelines, updated guidelines, and we need more and more such tools to be developed in future for the holistic approach. So what are the therapeutic hurdles in the management of neuropathic pain? So as I said, comorbid symptoms like mood swings, depression, anxiety, sleep problems, neurocognitive impairment are quite common. Most first-line drugs have higher adverse effects which lower the patient compliance and treatment adherence. And inadequate therapy response to the first-line treatment due to not addressing the root cause. So we only tend to focus on the drug treatment and we tend to overlook the root cause. So only 30% of the patients experience a pain reduction of about 30%. And this is also very important to note that prolonged use of these medications which are used for the treatment of neuropathic pain can lead to desensitization of the receptors and can lead to increased side effects. So what is the treatment algorithm as far as the drugs are concerned? These are the first line agents. The gabapentinoids, the alpha-2 delta ligands as they are called, which includes the pregabalin and the gabapentin, tricyclic antidepressants and the SNRIs. Serotonin, norepinephrine, ethylene. These are the first line agents. Then opioids, they are the second line agents including tramadol. Cannabinoids are the third line, and the fourth line agents include lidocaine, methadone, lamotrigine, lacosamide, tapentadol, and botulinum toxin. So, as I said, gabapentin and these gabapentinoids and SNRIs, DCAs are the first line agents. And when the response to these first line agents is inadequate, then we should consider adding additional agents. So these are the first line agents. Gabapentin, pregabalin, monotherapy or in combination with norepinephrine or duloxetine. These are the first line agents in the management of neuropathic. So what are the guidelines and the recommendations as far as the gabapentin is concerned? As per American Academy of Neurology, it is accorded a level A drug status in the treatment of post-herpetic neuralgia, gabapentin, and level B drug in the treatment of diabetic neuropathic pain, diabetic polyneuropathic pain. As per the European Federation of Neurological Societies Task Force, it is level A drug, this gabapentin, in the management of trigeminal neuralgia and chronic radiculopathy. So, not going to the details. So, we can see that as per all the reputed societies guidelines, gabapentin is the first line agent in the management of neuropathic pain. So this was a study published in 2002, in which they studied around 1100 patients, and what they basically investigated. So this x-axis is the VAS score, this is the pain score, and these 1100 patients comprised of pain syndromes of different categories. So some like 30.4% had painful diabetic neuropathy, 20% had non-specific neuropathies, 12% had trigeminal neuralgia, around 9% had central pain syndromes, and around 8.4% had post-herpetic neuralgia. So we can see that as compared to the baseline, after adding the gabapentin, there was a marked reduction in the VAS score in all the categories. So again, so this was gabapentin monotherapy. So what about gabapentin and nortriptyline combination, which is commonly used in our practice? So we have some Indian data on this. So this was published in the International Journal of Research in Orthopedics 2020. So they showed that gabapentin, when given in combination with nortriptyline, significantly reduces the neuropathic pain more than either of the agents alone. And the pain score is found to be significantly reduced from the second day of administering the combination therapy. And there is almost 18% reduction, greater reduction in the pain with gabapentin and nortriptyline combination as compared to the monotherapy. And not only that, but it also, this combination also improves the depression and the other psychological associations like depression, mood disturbances, sleep disturbances, walking ability, and overall health related quality of life diseases. So the same study, and they actually around 500 patients were there, and they investigated different outcome metrics like pain intensity score, the mean general activity score, the sleep score, and the mood score, and we can see that. And the effect was sustained also. Like we can see the first week, the second week, and the fourth week, in all the categories of the outcome metrics, there was a significant improvement after addition of gabapentin and nortriptyline combination. So basically, the result of the study was that there was an improved efficacy parameters reflected in terms of improvement in symptoms such as fatigue, lower leg pain, weakness, numbness, tingling, burning, etc. So this combination works well. So what about pregabalin? So this was again a study published in 2014. It was a Japanese study. A total of 103 patients were studied and they received pregabalin. And again, it was a heterogeneous category which comprised of different categories of pain syndromes like post-stroke pain, spinal cord injury, or multiple sclerosis. And it was a follow-up study of around 53 weeks. So it was a 53-week follow-up study. It was a multi-center, open-label study, and in which pregabalin was given at the dose of 150 to 600 milligram per day. And the outcome metrics were the VAS score, the SF-MPQ, and the MBPI-10. So simply put, the VAS score basically it tells us about how much reduction in the pain happened. And this SF-MPQ and MBPI-10, they basically tell about the functional, how better the functional outcomes were. Pain is one thing, and the associated symptoms, the quality of life increases, and the associated symptoms also, they are equally important. And these things are reflected by these two scores, SF-MPQ and BPI. So what was the outcome? So there was improvement in both the SF-MPQ and BPI-10 scores in all the patient subpopulations. And it was reflected from the change in the scores from the baseline. So the same study, basically you can see the graph. So these are the different category of patients having pain, the spinal cord injury, post-stroke, multiple sclerosis. Post-stroke, I mean the thalamic pain syndromes basically, which have very excruciating pain sometimes, those are called Gangrene syndrome. So this is the average. This graph tells us about the average outcome. In all the categories, we can see there was an instant benefit at 4 weeks, and the benefit was sustained at 52 weeks also. at the completion of the study. So again the same thing, this was a different study, and they again studied pregabalin versus placebo. It was studied post-traumatic peripheral neuropathy way. It was again a randomized double-blind placebo-controlled study. We can see that the pregabalin, the dashed line is the pregabalin, the solid line is the placebo. You can see that the reduction in the pain score was significantly more in case of pregabalin as compared to the placebo. So again, this was also a very important study, very interesting study. We often prescribe fixed dose combination of pregabalin and duloxetine. So it was again a double-blind randomized parallel group study, and in which 298 patients were included, and 148 were assigned this group. 148 received the FDC, the fixed dose combination, and 150 received almost same numbers in both the categories. We can see in the graph that the outcome, reduction in the pain scores was almost similar in the pregabalin duloxetine group as what it was in the reference group of pregabalin monotherapy. So to conclude, in patients with moderate to severe neuropathic pain due to different etiologies, the analgesic effect demonstrated by FDC of pregabalin and duloxetine was comparable to pregabalin high dose monotherapy. Now, what is the advantage basically? So, if you give a higher dose of pregabalin, the side effects will be more. But in this combination, pregabalin and duloxetine, we do not give very high dose of either drug. So, the efficacy tends to add up and the side effects are less. So, this is the whole idea. So, let's understand the pharmacokinetics of gabapentin. So, how it is absorbed from the gut. So basically this gabapentin is absorbed from the proximal upper intestine, and this is the transporter, L-amino acid transporter 1, LAT1 transporter. This is the transporter to which the gabapentin attaches and is internalized and activates the downstream pathways. So any drug which crosses the proximal junction.
Please conclude, Dr. Bansal.
Okay.
Yeah.
So,
regarding the SCS and conclude. Thank you, sir.
So I'll just rush to the slides.
Yeah.
So this receptor is very interesting. It's a saturable receptor. So that means that if you increase the dose of gabapentin, the receptors will get saturated, and there will not be additional increase in the efficacy if we increase the dose. Rather side effects will accrue. So that we have to keep in mind. So this is the disadvantage, and so this is the saturable pharmacokinetics of LAT1. So what is the option? The option is, rather than giving a single high dose, we can divide it into BID or TID doses. So but again, as we can see, this is non-linear kinetics. So there are peaks and there are troughs. So at the peak, we'll have side effects, and at the trough, we'll have breakthrough pain. So this is also not acceptable. So what is the next option? The novel drug delivery system. We are talking here about the GRS system, gastroretentive gabapentin system. So basically, this technique allows the tablet to remain in the stomach for a longer time, and because of which, this system releases the drug slowly over a period of time, so that it's not saturated. And this was a study which showed the comparison between the gabapentin TID dosing and once daily GRS system. As we can see, there is reduced Cmax and prolonged Tmax, and the area under the curve is similar in both TID as well as the single GRS. So definitely it is better. The GRS preparation is much better. So the other side effects also are less in the GRS system, like dizziness and somnolence. So, and there is a role of nutraceuticals also as disease modifying therapies in peripheral. I'll just name them. We have methylcobalamin, alpha-lipoic acid, folic acid, inositol, chromium, selenium, zinc, magnesium, vitamin D, etc. So they have different molecular targets like G protein coupled receptors, neurotransmitters, ion channels, inflammatory mediators. So we have B12 and we have inositol, chromium. They have different effects on the metabolic parameters. I'll not go into the details because of time constraint. So selenium, we have selenium. Selenium basically reduces the oxidative stress and reduces the release of pro-inflammatory cytokines, which have a significant role to play in the pathogenesis of neuropathic pain. So again, zinc is very important. Alpha-lipoic acid, we have many studies which support the use of alpha-lipoic acid. N-acetylcysteine, of course, we have. Besides neuropathic pain, we have other traditional uses. I will not go into the details. These are the diseases in which NAC can be used. So what is the role of rational polytherapy? So it depends on targeting multiple mechanisms simultaneously, and there is improved pain control with lower individual drug doses, reduced side effects through dose sparing, and better functional outcomes. So we have other lifestyle interventions also, like physical activity, diet and nutritional support, psychological and sleep support, rehabilitation, like physical, occupational, pain management therapies. Meditation, of course, is very important. Different types of meditation techniques like mindfulness, guided visualization, breath awareness meditation, body scan meditation. And this was a very interesting meta-analysis systematic review, which showed the role of meditation-based therapies and how it improves the outcome parameters in neuropathic pain. So, thank you. I'll conclude my talk here.
We'll have the question answer session at the end, kindly.
Yeah, so we'll have the next talk by Dr. Manish Sarkar. Where are you, sir? Please come. And he is going to talk about addictions and de-addictions. How do you go about? Dr. Manish? Go ahead, sir. All yours.
उधर की लाइट थोड़ी सी जला दी हाँ नीचे से यहाँ नहीं यार बस बस
Can we have some silence at the back, please? Manish, please start, sir.
Good evening, everyone. I'm Dr. Manish, consultant psychiatrist. So today I'll be talking about about abuse and its addiction. So what is drug abuse? Going into the definition, drug abuse is the non-permissive consumption of certain substance that may lead to physical and psychological dependence. Going to drug addiction. Drug addiction is a psychological and physical inability to stop consuming a chemical, a drug or a activity or a substance even though the person is aware that it is causing both psychological and physical harm but unable to prevent it from consumption. So this is the vicious cycle. Drug leads to a drug abuse over a period of time, and if it continues, it leads to drug dependence, and this vicious cycle continues. Now, what are the commonly abused drugs? We'll have a very short, crispy presentation, then we'll have a walkthrough of our center also. So, commonly abused drugs, these are marijuana or cannabis, cocaine, a stimulant, heroin, an opioid-based drug, alcohol, prescription drugs, mainly benzodiazepines and other hypnotics, various inhalants and solvents like various paints, glues, like various solvents which are used in case of painting in our houses. They can also be used by certain people in terms of addiction. What is the statement of the drug abuse or addiction? Now, more than a half of the billion people use drugs globally. It is alarming considering the number. Around 62.5 million people use alcohol in India. I am talking about abuse and an addiction. It is a huge number. Nearly 9 million people in India use marijuana and cannabis. Again, it is, I've used the term use, but basically I'm talking about abuse and addiction. Almost 2 million people use opioids, that is heroin, brown sugar. It also includes the prescription drug, like a lot of us will write it, like spasmoproxibran, and also the cough syrup which contain codeine syrup. So, Fortwin injections, I mean one of the integral part during labor. So a lot of people get hooked onto it and develop dependence, which needed to be taken care of. Approximately around 2.6 million people have sedative and hypnotic dependence in India. These are the prescription drugs, benzodiazepines and other hypnotics. Around 20% of various drug users can be classified as dependent users. So number of people who are using a drug, around 20% of people can be classified as dependent pattern of users who need urgent rehabilitation in terms of their treatment. Continuing the statement of the problem, that drug abuse is an exclusively an urban phenomena. It is a myth right now. It is seen everywhere. Villages, suburban areas, small towns. It's not that it's only limited to bigger cities, it is everywhere. Injecting drugs are fairly widespread throughout the country and not only restricted to the northeastern states. Earlier it was believed that majority of the injectable or majority of the drug abuse, people who abuse drug have dependent pattern of use are mainly hailing from the northeast. That concept have changed. It is prevalent everywhere. Low enrollment in the treatment programs and long duration of drug use before people seek treatment, it remains a key area for concern because the duration over which the drug dependence is there and seeking help, there is a long duration between it. The highest number of drug dependence is seen in our country, in Uttar Pradesh, Maharashtra and followed by Punjab. It's not that the other state doesn't have, there is an alarming number of people, but these are the three main states where you see drug dependence more according to the current data. Now what are the 5 C's of addiction? How you define addiction? So it is a chronic use of any drug. Person continues to use the drug for a longer duration. How it becomes a dependence? Because there is a loss of control over the use. So once you are using a substance, alcohol, a lot of people do consume, but then there is one thing called a social drinking. You decide, I have to take 1 drink or 2 drinks in 15 days, in 30 days, but when you lose control over it, like there is a development of tolerance, you take multiple packs a day and if it becomes an integral part of your life, then you know that it is going somewhere else and you have developed dependence which is needed to be taken care of. So there is a kind of compulsive use for the drugs. It is this is how the addiction is being defined. And using the drug despite negative consequences. You are aware that your liver is getting damaged, you are facing dysfunction within the family, there is occupation deterioration, but in spite of knowing everything, you don't have a control and you keep on using the drug and the problem continues to become more grave. So there is craving of the substances which normally a social user won't have, but once you develop dependence, the cravings are also there. So now there are different age groups in which, the presentation of drug dependence is there. It's a psychosocial factor because we can be from different speciality, but addiction is a kind of a thing which a lot of our other speciality people also we treat, but psychosocial part is the main aspect which we psychiatrists or psychologists we normally treat. So I'll be discussing mainly that. So curiosity, so there is a curiosity, self-esteem, peer pressure, which because of which a person takes drug, mainly in case of adolescents, adult modeling of behavior, out of boredom. I'm getting bored, I'm free, I'm empty, so you resort to drug. There is something which gives me some, it gives me a pleasant feeling. So, but then you continue to derive the pleasure out of it, and over a period of time you become dependent. Feeling of alienation from the environment, relief of discomfort. It can be both emotional and physical pain. Depression. I have just written depression because it is the prototype of, if I say, of all psychological disorder. But speaking frankly, any psychological disorder, anxiety, psychosis, schizophrenia has a very high comorbidity with addiction of various kinds, mainly alcohol and tobacco. So depression, family disruption or dysfunction, issues within the family can also trigger a drug use and it can become a dependent pattern of use. So now a little bit of discussion discreetly. Curiosity, this is the desire to know about something. Exploration, which is seen mainly, they want to explore the world for adolescent. In this case, knowing how to do drugs, it affects oneself. Peer pressure, since values are not just taught, they are also being taught. The specialization process, the socialization process is also a factor of drug abuse. So a lot of the times, like when a person, adolescent, goes to a college, he invariably becomes a part of the group. Nowadays, frankly speaking, we see a lot of people in various colleges, professional colleges. I have my personal experience also, would be using drugs of various kind. So sometimes there can be one or two people who might not be completely aware that, how dependent is all about, what are the various drugs. But they feel alienated. They feel they are not being included in the group. So in order to gain the acceptance and approval from other members within in the group, they resort to use drugs and they become dependent. This is very common, peer pressure. So adult modeling behavior. So it's modeling behavior. Every child models their family members, mainly the parents. If father, there is a genetic link for any kind of addiction. But if the father or the grandfather use alcohol or say drugs, over a period of time, the child also develops curiosity and a kind of he wants to explore what it is. And my father is drinking every day, my grandfather is drinking every day, why not me? So, adult modeling of behavior, my father takes in that way in the evening, wearing this kind of clothes, child start doing all those things, and over a period of time, in a hidden manner, then later on it is a fruit of full-blown dependence. Low self-esteem, a person gets courage and confidence from a particular drug he or she takes. So a lot of the times, whether facing an interview, whether for a job interview or for a situation, while the person feels that I don't have enough that courage or self-esteem to go on with my points, but if I take alcohol or some drug, it gives me a lot of confidence to put forward my views. So they resort to various substances, and over a period of time, if it is being repetitive, it becomes a dependence. So again, continuing boredom, a lot of people, I am getting bored, I am empty. Now being empty or being bored, not being occupied with any kind of a work or task is also one of the reasons for addiction. So as I say, the devil's playground is an empty mind. You resort to any kind of a drug and it becomes dependence over a period of time if you continue to use it. Feeling alienation, which I've already told, sometimes people, especially teenagers or even younger adults, feel they are being casted out of the group, but to get the approval and being inclusive of the part of the group, they start using it, and over a period of time, they become dependent. So depression, yes, a state of mind in which carries a very high comorbidity with various drugs, alcohol, marijuana. A lot of the times even these drugs become the reason for depression and anxiety. So a vicious cycle is created. So now majority of these substances exacerbate the disease process also. So depression is a prototype I mentioned, but anxiety, psychosis, other psychological disorder, they all can have an exacerbation or even can be come into the process if there is a drug dependence. So there is a very high comorbidity of any kind of addiction along with psychological conditions. Disruption within the family, if there is an issue within the dynamics of the family, there is a chaotic environment. मम्मी पापा हमेशा लड़ते रहते हैं, पापा कभी मम्मी की नहीं सुनते, he is being very authoritative. I have seen him being very nasty and beating up my mother. All this kind of chaotic environment. Now everyone wants peace. Parents are not amenable. What shall I do? But I need to find peace. I need to feel happy. The person resort to various drugs. कोई friend बोल दिया कि भाई try कर ले मुझे अच्छा लगेगा, कोई issue नहीं. वो try फिर try नहीं रहा, and over a period of time, a person develop dependence. So family dysfunction is very important in terms of causation. Now, what are the signs of drug abuse? Physical signs, just running through it. There can be red eye or bloodshot eyes because of substance use. Pupils can be larger or smaller than usual because of drug abuse. There can be changes in the appetite. Either you tend to take more, your appetite becomes more, or a lot of the times it becomes less because of the various type of drug use. So there can be weight loss or weight gain depending on the various type of drugs being used. There is deterioration in the physical appearance. Understandably, if you lose weight or tend to gain a lot of weight, it is a matter of self-esteem and confidence. Those issues also invariably comes up. You tend to take more drugs, and all this particular vicious cycle continues. Unusual smell or breath. Alcohol is very easily identifiable with its smell, but I tell you, a lot of people, it's not directly always because of the drug that there is smell coming from the breath of an individual, but personal hygiene and grooming is significantly affected in people with alcohol and other drugs. Those people who have a dependence, you might feel that they are well groomed, but they might not be taking bath for a long time. Personal hygiene and grooming get significantly affected. That can also, you might not have brushed, not maintained, so that can cause smell or breath from those individuals. There can be impaired coordination because of the involvement of the cerebellum on few occasions. What are the behavioral warnings? Poor work, your occupation suffers. Decline in the performance. So students, if they get addicted, their overall scholastic and even the college, their overall academic performance suffers. There can be a financial problem. At the end of the day, whatever the drugs you are using, you are not getting it for free. Initially, your friend might introduce you to the drug, but then later on you have to buy your own self. And because of the tolerance, you need to procure the larger quantity of drugs. So there is a financial burden. Also, secretive behaviors. मेरा बेटा है, पहले आके हमारे साथ डिनर करता था, इकट्ठा बैठते थे, दो बातें होती थी, हम ये वेब सीरीज साथ में देखते थे. There is to be more quality time within the family. आजकल बाहर से आता है और सिर्फ तुरंत अपने रूम में चला जाता है, दरवाजा बंद कर लेता है, और मॉर्निंग में भी ब्रेकफास्ट के पहले तो टाइम लेता था, जल्दी से निकल जाता है. So there is a escaping behavior. So when you notice similar kind of escaping or secretive behavior, it can raise an alarm that there can be something, there can be a drug dependence. Sudden change in friend and associates, अचानक different friends नए बन गए, घर पे आ रहे हैं, पार्टियां चल रही हैं. Yes, youngsters do it. But if you see that there is a change in the frequency and intensity, and there is a newer number of people being included, and it should raise an alarm that something is going wrong. And I tell you, a lot of the times it can be a drug dependence. Lack of motivation and being withdrawn. Pehle he was the person was had a spark. He had a social presence, but once have started, he wants to remain aloof. He prefers solitary activities, does not interact much. So those kind of behavioral issues are also very common in addiction. There can be unexplained anxiety because of as a behavioral part of drug use. Now, what are the effects of drug use to oneself? So there can be changes in physical and psychological aspect, as I've already mentioned. Any kind of psychological disorder, depression, anxiety, psychosis, all can be there as a comorbid psychiatric disorder in a patient with drug dependence of any kind. Drug abuse leads to loss of coordination, there can be poor judgment and other cognitive deterioration if it continues. There can be slowed reflexes, body reflexes, there can be distorted vision because of intensive drug use, there can be memory loss, and again as I mentioned, and that deterioration. Sure, sir.
Yeah, Manish, please continue.
Sure, and the memory loss because of drug use, loss of consciousness, and overdose can we all know can even lead to death. So, to a family, there can be dysfunction of the family, there can be disregarding of family needs, people because oblivious of their responsibilities, feeling of abandonment, anxiety, fear, rage, anger outburst, violence, everything can be there to the family, embarrassment or guilt which brings to the family, and family wish to ignore or cut ties with a person who is abusing the substance. This is also not uncommon. Now to the community at large, what happens? What are the consequences? There is a higher crime rate. So it is seen a lot of people of the crime, it is seen if we check properly, a lot of them have a drug dependence of some kind. There can be economic consequences we have discussed, more public service demand because of the existing pattern of drug use and the great problem it has become over a period of time. There can be loss of fame and reputation. Understandably, it carries a lot of stigma, so loss of fame and reputation would be there. Now, what are the health complications? Drug and alcohol use impacts everything from heart to ball. Substance abuse can lead to abnormal heartbeat, so myocardial infarction. Injectable drugs can result in collapsed veins and infections in the heart valves. Some drugs can also stop bones from growing properly. Using drugs over a long period of time will also eventually damage the kidneys and liver. Sharing the needle used to inject certain drugs result in diseases like hepatitis C, B and HIV. Legal consequences, use of illegal drugs or possession of it can lead to legal consequences, can be tried by the narcotic law, which is, I tell you, very strict. Theft and robbery result in legal consequences because these are very common in people with addiction, be different social strata they belong to. Financial problems, drug and alcohol are expensive, especially when there is a dependent pattern of use. You need to procure it on a regular basis. Substance abuse also impacts productivity and success rate in work and academic performance.
Manish, please write up.
Yeah. So, seeking help from the parents and peers, it is important. Be bold, and you need to be very assertive to say no. Alternate activity, joining sports or social activity, it not only increases your social circle but also improves your social esteem. Avoid the situation where people will be using drugs. It is better to avoid certain situations. Continuing, have a positive self-esteem, be involved in a worthwhile activity, have a sense of accomplishment is important, so it improves your self-esteem, have a clear defined goals for oneself, so there is less chance for ambivalence and develop a drug problem. Be committed to follow rules and law, it's very important, be reared in a loving and functional family, so family dynamics plays a vital role. In conclusion, I would say drug abuse is a serious psychosocial problem. It is often difficult to be cured, but the intervention has to be done anyway. The best way to avoid any tragedy is to seek help and never suffer in silence. Because a lot of people suffering, they have a strong denial that never come for help. So you know someone, you need to bring them to help. Mere building of treatment center will not be enough, and millions of drug users in the community need to be motivated. There has to be more group community involvement for the treatment process, and they have to be informed and encouraged to come forward and seek treatment. Thank you.
The final talk, let me introduce Dr. Gurmeet Bansal. I'd probably like to introduce Dr. Biplab. Mukhopadhyay, go ahead.
Good evening, friends. First of all, I must thank Dr. Sushil John sir to having me invited over to moderate this session. And I feel very happy in introducing our young dynamic laparoscopic surgeon, Dr. Biplab Mukhopadhyay. He has, apart from the basic laparoscopy, he has taken advanced training in advanced gynae laparoscopy with a special interest in gynae oncology, and he is working as a senior consultant in various hospitals in South Delhi, including the Apollo Hospital, SCI Hospital, and Cloud9 hospitals. He is going to show us various videos on tricky cases in gynae laparoscopy. Over to Dr. Dr. Biplab.
Thank you very much, ma'am, for the nice appreciation. And thank you, Dr. Sushil Chauhan and Physician Forum of India, for giving me such an opportunity to present such kind of videos in this great audience. Just I'm starting. I'm Dr. Mukhopadhyay, gynecologist and laparoscopic surgeon. Just a few videos of mine. I'll start. This one. My first videos of laparoscopic management of scar ectopic pregnancies. This is a scar ectopic pregnancy. You know all the pregnancies, ectopic pregnancy. This is a scar ectopic. This is within the caesarean scar. This pregnancy, this is a uterine cavity, this is a whole empty, and this is the pregnancy within the caesarean scar. The pregnancy is at the level of internal os. This is the whole gestational sac, which is greatly and was nicely imaginating within the caesarean scar. This is very difficult to manage by DNC. Basically, if you go for DNC, you will do a lot of mistakes because it bleeds a lot. So that's the main management by laparoscopy. Just we are doing a dissection of bladder dissection by laparoscopy, and just the carbon dioxide making a good plane within the bladder, and we are dissecting the bladder. And you can see the bluish discoloration here, and this is the bulging of the caesarean scar. Here is the pregnancy is at that level of the scar. So there is very much thinning of the myometrium here. This is the bluish discoloration and bulging of the caesarean pregnancy. Now bladder has been properly dissected down. Now we will go for the taking care of the caesarean pregnancy. We are giving an incision of the caesarean crown, caesarean scar by using a harmonic scalpel. The harmonic scalpel is very good tool for this kind of management. And this is the pregnancy is coming out so beautifully and so nicely. You can see that. You can do, need not go for any DNC for this case. If you go for DNC, in this case of invaginating scar ectopic pregnancy, you will land up in lots of complications, and patient may bleed a lot, and you can land it up in a hysterectomy also. There are so many cases reported. Now this is the caesarean pregnancy. This is a whole gestational sac which is coming out of this scar, and just you can see that. This is the whole pregnancy, and now the scar is visualized and opening is visualized, and we just resuture it, and that's the end of the procedure, and there is no bleeding at all. Where I am not using any kind of drugs, any kind of vasopressin, any kind of uterine artery ligation. This is the only surgery we are doing. This is the closure. This is the end of the surgery. So this is a tricky surgery, very tricky surgery. You never go for DNC in such cases because you will land it up in lots of complications. So go for laparoscopic management, which is very easy, and you can do that very nicely. My next case is laparoscopic myomectomy. You know that myomectomy is myomas are very common. There are two concerns of myomectomy. One is the bleeding issues, which is very common in the myomectomy. For that, we have to, and another is you have to find a defined plane. So for bleeding issues, we can use the vasopressin injection. Vasopressin, we have diluted the vasopressin injection in 200 ml normal saline with 20 units of vasopressin and injected over the fibroid and myometrial junction. This is the blanching of the whole blanching of the uterus, and we creating a good plane between the uterine myometrium. This is how we are cutting the capsule and using the harmonic scalpel. Go. This is the only scar, only just cutting the capsule, and we are going and cutting the capsule. Now the fibroid will come up automatically, will prop up automatically, and will give a traction and counter traction so that the fibroid is coming very easily and very nicely without any blood loss. You can see there is no blood loss anywhere, no blood loss. Just this is the fibroid is coming out, and just we give a traction and counter traction so that fibroid come very easily. This is the traction and counter traction using the myoma screw. This is the myoma screw. This is the fibroid. This is the whole uterine, and this is the wall of the uterus. Now just taking out the uterine fibroid and resuture the uterus and reconstruct the uterus. now this is the fibroid has been removed. Now use one kind of suture which is called V-lock or Berg suture, which is a knotless suture. It is a very good hemostasis effect and as well as very good in the reconstruction, total reconstruction of the uterus. If done the total reconstruction of the uterus, there is no remnant here, there is no bleeding at all. This is the end of the surgery. This is the mammogram. This is the second surgery. Now next surgery is the retroperitoneal dissection. The retroperitoneal dissection we have to show is very difficult case of gynae laparoscopy where the anatomy is not properly defined, like grade 4 endometriosis, cervical fibroid, very large fibroid uterus. When you are going for laparoscopic hysterectomy or clearance of grade 4 endometriosis, we need to go for retroperitoneal dissection to identify the vital structure in the retroperitoneal space, which are the external iliac artery, internal iliac artery, external iliac vein, and uterine artery at its origin. And mostly the most feared of the gynecologist is the ureter. You have to dissect the ureter in lots of cases, of difficult cases. This is the broad ligament. This is the broad ligament peritoneum. This is cutting the broad ligament peritoneum with the harmonic scalpel. And there is no bleeding at all. This is the way going along the vasculature. This is just after that we just can identify the external iliac vessels, the external iliac vein, and external iliac artery. This is just next step will be there. This is the vein, and this is the artery. And now this is the artery and this is the vein of external iliac. This is cord-like structure, which is the continuation of the internal iliac, which is the obliterated umbilical artery. Now we just dissect the uterine artery, which is the first branch of internal iliac artery, and the ureter. This is the most vital structure in case of grade 4 endometriosis. We have to identify the ureter. Basically, damage of this one is the ureter. This one is the ureter. The ureter damage is very common in the grade 4 endometriosis, and we are doing by carbon dioxide dissecting the plane. This is the paravesical space. We are creating the paravesical space here. This is the obliterated umbilical artery, and we will search for the uterine artery so that we can ligate the uterine artery at its origin, not at the level of the cervical region. Because in case of grade 4 endometriosis, we are not doing the hysterectomy. We are doing only the uterus saving surgery and the saving the ovaries also. This is the uterine artery. You can see the uterine artery is pulsating here. This is the first branch of the uterine artery. This is very clearly defined here. And now we have to find out the ureter. Ureter should be medial and beneath the uterine artery, which is a water under bridge. This is a very common term, water under bridge. And the bridge is the uterine artery and water is the ureter. Now this is the ureter, you can define this. This is the ureter, this is the uterine artery. This is the obliterated umbilical artery is going there. This is the external iliac vein. This is the external iliac artery. All the retroperitoneal anatomy is clear here. Then you can proceed further any complicated surgery after defining this kind of anatomy. Basically, in these difficult surgeries, you have to define, you have to not to injure the ureter. The ureter is the major concern for gynecologists as well as bladder. Bladder is very common, injury is very common, it's a very friendly organ, you can repair the bladder very easily. But ureter is a major concern because there are thermal unnoticed injury in the ureter. Now, just uterine this is the uterine and this is the hole. You can identify this is the ureter, this is the uterine, this is the origin of the uterine, here is the origin of the uterine, this is the external iliac, this is the obliterated umbilical artery, this is a continuation of internal iliac artery, this is the external iliac vein, and this is the external iliac artery. All the retroperitoneal anatomy is here, this is the paravesical space, and this is the pararectal space. So this is the very important for any difficult case of laparoscopy. You have to identify this. Now my next video is the laparoscopic management of wall prolapse. This is wall prolapse. Wall prolapse is this is a female of 67 years. He had undergone an abdominal hysterectomy. After that, he underwent a cystocele, complete cystocele. Uterus is not there. This is a total bladder. Now, how you will repair laparoscopically? The next step is just will show you. This is the wall. We are just pushing a manipulator here. We are dissecting the bladder anteriorly to put a mesh over the anterior wall of the vagina. And this is the posterior part. Just pushing, we are dissecting the bladder here, and so that we can put a anterior arm of the mesh here and just fix it. Okay. This is the posterior peritoneum. This is the rectovaginal space, and we are creating a space within the rectovaginal fascia, and so that we can put the mesh beneath this fascia, so that the mesh cannot be exposed to the other vital organs, and to prevent erosion of the mesh. Okay. This is the dissection. Now dissection has been complete from anterior and posterior body section. Now with this mace will be fixed to the sacral promontory. Sacral promontory, you know all well aware about the sacral promontory. So we will use a polypropylene fix a polypropylene mace at the level of the sacral promontory. Now this is the dissection of the posterior peritoneum. Now we will go for the sacral promontory. Now this is the sacral promontory. The sacral promontory dissecting the peritoneum of the sacral promontory, and you have to take care of the median sacral vessels. Which are very important. Median sacral vessels are very tortuous and they can bleed torrentially. So you have to take care of that. You should not injure the median sacral vessels during dissection of the sacral promontory. Now after dissecting the sacral promontory, we go for dissection of the lateral pelvic wall and we make a tunnel over the lateral pelvic wall so that we can put the mace over the lateral pelvic wall beneath the peritoneum. This is very tricky case because ureter is right here ureter. Ureter is going here because you can see clearly the ureter. We have to take care that you should not injure the ureter. This is ureter. So now we are creating a plane of the lateral pelvic wall. Total tunnel has been made here. After that you have to fix the mace. Now the total peritoneal tunnel has been done. Now I will fix this is the mesh over here. This is the anterior mesh fixation over the anterior wall of the wall, and this is the posterior wall of the wall. And we will mix this is a brief case. We have to take 5 to 6 sutures over the anterior and posterior wall as well, so that you can properly fix the mesh here. Now mix has been fixed here. Now we'll fix the base over the sacral promontory. This is the sacral promontory using the tacker here. This is the surgical tacker. Then tacker 1, tacker 2, tacker 3 and tacker 4. We'll put the 4 tackers here so that mix can be fixed here at the level of sacral promontory. Then you will peritonize the whole mace and the whole wall will be hitched up. Now that we are closing the peritoneum here, as the peritoneum is closing over the ward here in the ward. This is the ward. The ward has been hitched up to the sacral promontory. This ward is up, not within the introitus. This is we are covering the peritoneum here. Now the peritoneum has covered over the ward. Now we cover the peritoneum over the lateral pelvic wall dissection where we made the tunnel here. This is the tunnel. Then we are covering the tunnel and we just closing the peritoneum over the tunnel so that we can cover the mesh here. Just total mesh has been covered under the peritoneum, and this is the final result. The total cystosis has been gone. The next case, this is hysteroscopy complete septal resection. This is a complete septum of the in this case. There is a complete uterine septum. This is a complete uterine septum. It is very difficult. There are 2 cavities. One cavity is 2 cavities. So this is a cavity, one cavity. We are dissecting the cavity. Now this is a monocular. This is called a Collins knife, and we are using the glycine media. This is Collins knife, and we are cutting a centimeter by centimeter so that you can go to the other canal also, other cavity. Now after cutting this, you can go, you can see that the other cavity will open very soon. This is the septum. You have to take care that you should not go too anteriorly, there is a bladder, and not too posteriorly, there is a rectum. You can injure both of them. So you have to be in the midline. This is now how the cavities has been opened. This is one the second cavity, this one is the first cavity, and this is the septum. Just we completely cutting the septum. This is the septum we are cutting, and you can see the final view. This is the cervical part. You left the cervical part because if this cervical part has been cut, there is a very obvious there will be cervical incompetency. The pregnancy will be aborted in the second trimester. So that's why we are not cutting the cervical part. This is the fundal part. The low cavity has been now reunited. The total septum has been cut, and uterine cavity is singular here right now. This is the one ostia visualized here. This is the one ostia of the uterus. This is the septum has been totally cut. This is the septum. This is the one another ostia, and this is the whole of the uterine cavity. Septum has been totally cut. This is the cervical portion has been left to prevent cervical incompetence. Next is this is a case of vault suspension. Just after doing a TLH, you just routing it with the vault suspension. We are taking the intersacral in my suture. This is the vault after hysterectomy. This is the vaginal opening. Just you are taking the intersacral here. You are taking the anterior posterior vaginal wall, and then taking the anterior vaginal wall and calvica. So that this sided vault has been supported here. Now, we have the closes. This is the vault has been supported by the intersacral at that level. This is intersacral. This is the vault. We have supported this vault with this intersacral. This is the vault suspension here on the one angle. So in another angle we also do that so that collapse can be prevented. I have done more than 500 hysterectomies. I never reported one case of vault collapse in my cases. This is another intersacral ligament. This is the posterior vaginal wall, and we'll bladder here. We're dissecting it. Now, this is the hysteroscopic view of this thing. Sorry. After dissecting the bladder, you can clearly see the hysterosis. This is the hysterosis. The hysteroscopic light is coming out here. This is the hysterosis, and you can just cut it and repair it. This hysteroscopy is coming out. This is the scar. This is the scar, and we'll repair it. Just we'll see the final view of the repair. This is where you bring the scar here, and this is the end of the view. This is the whole hysterosis has been repaired. Thank you.
I think Dr. Manish has a video to show. Just a 2-minute video. 4 minutes. 4 minutes? Go ahead, sir.
सब ब्लैक आ रहे होते हैं लाइट नहीं ब्लैक नहीं
So it is a walkthrough of our center. It's around 4 minutes video. नहीं साउंड नहीं है.
Hello everyone, my name is and I am the director of Road Wellness Rehab Center. Road is a wellness luxury center situated in DNF Chhatarpur Farm with peaceful and serene environment for your recovery needs over addiction and other psychiatric disorders. So walking into our outdoor activity and open space area, we provide sports activities like volleyball, football, cricket, and for this physical fitness, we have yoga and meditation instructors coming in the morning to train our clients for their physical recovery needs. So walking towards our swimming pool area so that our clients can experience water therapy as well. So this area is our session station plus the classroom also. So we have a library over here for the patients who want to read and write, and our psychiatrists and the psychologists are taking psychoeducation sessions, plus our 12-step therapists are conducting group therapies for the patients who are suffering from addiction as well as psychiatric disorders. So come on, let's have a glimpse of our indoor areas. Moving into a spacious and beautiful lounge area. So for our clients, we have this space so they can have their group talks and enjoy their movie sessions. So then sliding into our dining area, a comfortable dining area for the clients, which has a buffet over here, and the patients can decide their own menu by a professional and trained chefs. So this is our indoor activity area. Our clients can play TT table and other board games over here. So moving forward to our pool table area, plus the balcony area over here for the clients. Also, we have triple sharing and a quad sharing room here for the clients. So if you talk about the balcony area, so it's a very green and clean environment for the clients so they can see. So this is our single occupancy room, which is occupied with air conditioning, heaters, fridge, and a flat LED screen with attached almirahs. So walking towards our double occupancy room. So our double occupancy room is fully occupied with two separate beds, a flat LED TV, a fridge, air conditioning plus heaters and attached dressing. So this is our workout and gym space for our clients to develop their physical and muscle health.
Hi everyone, I am Dr. Manish Sarkar, Senior Consultant Psychiatrist and De-addiction Specialist. I am also the Founder Director of Roar Wellness Private Limited. Here in Roar, we treat all kinds of psychiatric disorders, mainly substance use disorders like alcohol, marijuana, cocaine, opioids and other addiction disorders like gambling. Irrespective of the substance use disorder, we also treat conditions like schizophrenia, bipolar disorders, and also severe forms of obsessive compulsive disorder and suicidal depressions. We have other paramedical staff and a workforce of around at least another 20 to 25 people to look after the patient here. Thank you.
Dr. Manish, what is
So everyone wonders why we kept this name ROAR. So ROAR means recovery over addiction and restart. So ROAR Wellness is a 30-bedded facility dedicatedly treating our clients for more than 13 years now. Thank you for watching and having a tour of our facility. Have a great day.
Wonderful, Dr. Manish and your lovely team. Thanks a lot. I would give it to my moderators. The first two sessions, Dr. Tulsi sir, and we had two wonderful talks. I'm sure there will be a lot of questions. I would like active participation from all of you. And last session, those wonderful videos by our young, vibrant Gynae Laparoscopic surgeon, Dr. Biplab. I always wrote his name as Biplab, but today for the first time I understood it is Biplab. So wonderful, wonderful. And Dr. Manish, I remember that famous dialogue from Sholay. हमारा नाम सूरमा भोपाली ऐसे ही नहीं है. Wonderful center, you know, we never knew you have such a wonderful center. I think it has improved a lot since I visited you.
That is the other center, sir. We closed it.
So the other center has been closed. It is the renovated another center.
It is another. It is the oldest one.
Wow, wow, great.
This is BLF farm.
Great. Dr. Tulsi sir.
So, friends, let me begin by saying that this was a wonderful talk. Two wonderful talks, not two, three wonderful talks. So let me begin with Dr. Bhaskar Shukla talking about neuropathy. So the commonest neuropathy today seems to be the diabetic neuropathy, peripheral neuropathy, known as DPN. So what is the etiopathogenesis of the diabetic neuropathy, and since we have two very eminent dermatologists here, can I name them? Any guesses? One is Dr. Chauhan, the other? He is gone, probably. Okay, anyway, let me begin by asking Dr. Bhaskar Shukla regarding DPN. So, why is DPN so common? And is it more common in type 1 diabetes or is it more common in type 2 diabetes? And why is it more common in type 2 diabetes? Tell us, sir.
Sir, diabetes, it's not only diabetes. Textbooks endorse nowadays that even in pre-diabetes, like borderline HbA1c values also, they also predispose an individual to develop neuropathy as commonly as full-blown diabetes, which are not. So it's not about type 1 or type 2. I have seen in my experience that both in type 1 and type 2 diabetes, patients tend to develop neuropathy. Sometimes, and it's quite common, we often prescribe nerve conduction studies, and patients have severe symptoms. They come to my clinic and I order certain tests to confirm the presence of neuropathy, and the test comes normal. So diabetic small fiber neuropathy, as it is called, diabetic small fiber neuropathy is not detected on conventional nerve conduction studies, and yet the symptoms are very severe. As regards the pathogenesis of diabetic neuropathy, we all know that diabetes is basically a vascular disease. It's an endotheliopathy. So the blood vessels affecting the blood vessels supplying the nerve fibers, the vasa nervorum, yes, they are affected, and that leads to the damage, basically the axonal damage. So this is most of the diabetic neuropathies are axonal neuropathies, and that too is length dependent. So what we mean by length dependent neuropathy is that the patient tends to develop neuropathy in the legs first, it ascends, and when it reaches the mid-thigh or the knee, then the hands are also involved. This is the typical pattern, the most common pattern. This is called length dependent or dying back neuropathy.
I'd like to have some interaction with Dr. Chauhan here. So as Dr. Bhaskar said, it's very common. Type 1 versus type 2. The diabetic neuropathy occurs earlier in type 2 diabetes as compared to type 1 diabetes. Why is that so, Dr. Chauhan?
Sir, I think you know the answer. Please give the answer.
So, as Dr. Chauhan correctly said, we all know the answer. And the answer is that these metabolic abnormalities with type 2 diabetes like dyslipidemia, like hypertension, like obesity is more seen in type 2 diabetes as compared to type 1 diabetes. So, peripheral neuropathy occurs earlier in type 2 diabetes as compared to the type 1. Why? Type 1 diabetes do not have many metabolic abnormalities like obesity, like dyslipidemia, like hypertension. So this is the crux. So type 2 diabetes, peripheral neuropathy occurs early, within 2 to 3 years, even at the time of diagnosis. Whereas in type 1 diabetes, it takes years to occur because the comorbidities like dyslipidemia, like insulin resistance, are not seen early in type 1 diabetes. Would you like to say that is correct, Chauhan?
Yes, sir. I think you have very rightly pointed out the very important factor of insulin resistance, which is responsible for the genesis and everything, all the pathways, the orbital pathway, and etc. in type 2 diabetes, which do not happen in type 1 diabetes. So, also it's important to remember that by the time we diagnose type 2 diabetes, the commonest complication that we diagnose at diagnosis in about 30% of all type 2 diabetes is peripheral neuropathy. So, this is very important. Peripheral neuropathy being a microangiopathy, being a microvascular complication, there are certain corollaries to it, if somebody has got a peripheral neuropathy, please do investigate this patient for retinopathy. Also investigate this patient for protein-creatine ratio because there might be kidney involvement. So it has other connotations. And they say if somebody has got a protein-creatine ratio which is older, it is almost a surrogate marker for coronary artery disease. So there is the microvascular and the macrovascular connection. Sir has very beautifully pointed out the difference. You had a beautiful presentation, Dr. Bhaskar. I wanted to know from you, when we start treating a patient with gabapentin, the problem with gabapentin is that there is a lot of sedation. And many of our patients are elderly. So, and my my contention has been that if you start a very high dose of gabapentin in these people, they are likely to have fractures, you know, when they get up in the night. And one fracture means that there is going to be a lot of morbidity and mortality associated with that. So what is the kind of dose that you start with it? And how do you build up the dose of gabapentin?
Sir, as you rightly pointed out, that the common side effect of gabapentin, especially conventional gabapentin. I am not talking about the GRS which I talked about. So definitely, as I mentioned in my presentation also, that it is not going to help if you suppose the patient comes with a severe neuropathic pain and we give him gabapentin. Usually we start with a lower dose and then gradually build up.
What is that lower dose?
Lower dose, sir, usually see 100 milligram doesn't work at all. It's useless giving 100 milligram gabapentin.
What is the dose you start with?
Yes, the lowest dose I start with is 200 milligram.
Is it in combination with NG?
Yeah, usually it is in combination with nortriptyline. So gabapentin 200 I usually start with, and then I gradually try to build it up. But the problem is that sometimes increasing dose will not increase better efficacy, rather than it will more add to the side effects.
How frequently do you increase?
Sir, depends on the...
What is the maximum dose?
Yes, sir. Maximum I have got to 1200 milligrams.
All right. Okay. And how do you increase? 200 milligram you start with. Then at what frequency?
So I call the patient at 2 weeks. If the response is suboptimal, I tend to increase. If the side effects become more severe, then I tend to switch to the GRS formulation.
What are the targets? Is it symptom relief, or you actually do a NCV and you find out that the NCV is improving and therefore now I will listen my dose?
So the problem with the NCV is that sometimes NCV can be absolutely normal. As I said, in a small fiber neuropathy, in which the pain is excruciating, the patient cannot sleep, virtually cannot sleep through the night, and the nerve conduction is normal. So we cannot follow it through nerve conduction studies. So then we have to start empirically. We have to start with gabapentin, gradually build up. And the beautiful part is, whatever the literature says, I have seen in my experience, over a period of time, the patient develops tolerance and the side effects tend to become less with prolonged use. So
You are also a pathologist, and we have several pathologists. We have Dr. Savita Satyava ma'am, we have Dr. A.S. Nigam sir, who was heading the Department of Pathology in RML. I want to know from you, what is the pathology of the neuropathy in a diabetic? What happens? Is it the axonal system?
The axonal system.
It is the axonal neuropathy. It is the axonal neuropathy.
Yes.
Now, so how much time does it take? We understand gabapentin, does it do anything to the axonal repair?
No, sir.
Or it just increases the pain threshold?
Yes, it is only symptomatic pain. Symptomatic.
There is nothing happening with the pathophysiological.
Alter the pathology.
Alright. Ma'am, you have a question? Dr. Mudar sir has a question.
I don't know much about any role of pregabalin.
Yeah, yes, sir.
In acute cases.
Yes, sir, absolutely. Pregabalin is equally effective as gabapentin. In basically American studies endorsed pregabalin as the first line therapy rather than gabapentin.
So 75.
75 to start with, we can increase to 150 or 300 milligrams.
Time कम है तब तक पूछे लोग.
No, Dr. Biplab has a question. Go on.
Good evening, everyone. Good evening, Dr. Bhaskar. I have two tiny questions. One, you partially answered having a normal NCV study in people with severe neuropathy. So I wanted your take around what is the issue with a normal NCV and axonal damage. How come it is normal? The other question is there any role of neuromodulation in neuropathy?
Absolutely, there is. So we frequently suggest the patient for TENS. You must have heard about TENS, transcutaneous electrical nerve stimulation. We do have spinal cord stimulation also, and we have neuromodulation in the form of DBS also, thalamic DBS for example. In very refractory thalamic pain syndromes, when the patient is incapacitated, you can go for thalamic DBS also. So definitely there is a role of neuromodulation. Peripheral nerve stimulation like TENS, I said, spinal cord stimulation, and thalamic DBS. And axonal, see, if there is axonal neuropathy, it will reflect on nerve conduction study. I am talking about small fiber neuropathy, which are not detected. So for that we have specialized investigations like QSAT and all. So it's not a routine actually, it's more research.
Do patients with herpes zoster?
Yes, sir.
The gabapentin and P-GABA are effective in
The guidelines recommend gabapentin as the first line choice.
Yes.
Dr. Kantu has a question.
Start.
Yeah.
Dr. Gupta sir.
Can I ask a question?
Yeah.
Why not?
Sir, we have seen a lot of patients coming to us with peripheral neuropathy. And this is such a common condition where we keep on giving medicines. How long the medicine will be given? And what is the outcome in future?
What are the target outcomes and how long will you get? Yes, sir. The duration is indefinite. There is no clear cut, like in some conditions, like sir told, post-operative neuralgia, we can give it for like 6 months or 1 year. We can taper the dose and see.
I think your question was particularly related to diabetic neuropathy, if I understood it well. Yes. Indefinite. Lifelong.
So although pregabalin and gabapentin do not alter the pathophysiology, but the quality of life is much better after pain relief is achieved.
So I think Dr. Bhaskar had capably said improvement in diabetic neuropathic pain. And I agree with him that neuromodulation is one of the way of the drugs which we are giving. But the other part is that to Dr. Tulsi and Dr. Chauhan that we always should differentiate between a neuropathic and a vascular differentiation between the pain. So that is very important in any patient and most of us miss it because nowadays we agree that most of the pains we just blindly say, okay, it is neuropathic. But we don't try to categorize it. My thing in clinical is I always feel the dorsalis pedis before giving a statement about whether it is neuropathy due to diabetic. And even in diabetic, it can be due to a patient who is a smoker. The other part, Dr. Manish, I agreed with your presentation about addiction. But I would like to love to hear about the ways you would like to de-addict the patient and the prevention of that. Dr. Mukhopadhyay, Biplab, beautiful presentation on your harmonic, and I really excel in it, the way you go with things with surgery because I am myself a surgeon. But the only thing I would like to know how good you are with robotics because does robotic play a differential role in the kind of laparoscopic or we should say they complement each other? Thank you.
Role of robotics.
The role of robotics are almost laparoscopy, they will complement each other. I think there is one advantage in robotics there is a finest movement of the instrument, that's all. I don't think there is a huge difference in between the laparoscopy, conventional laparoscopy and robotics. This is the only thing which is the magnification of the vision and finest movement of the instrument and your access to the deeper structure. This is the deep into the camera. These are the three advantages of robotics, but we can do it only by laparoscopy also. We are doing all the cases, difficult cases, on most difficult cases we are doing by laparoscopy. I think grade 4 endometriosis and big cervical fibroid, big large uterus is robotics is lesser. I think laparoscopy, conventional laparoscopy better option than a robotic in most of the difficult cases.
Hello. But Bhaskar, I just want to ask you one thing. Have you come across CRPS syndrome?
Yes, sir. Yes, sir.
CRPS syndrome. What is the treatment for this syndrome? It's sort of a neuralgia only.
Yeah.
It's very painful.
Yes, sir.
We have not come across any treatment for this kind of syndrome.
Sir, again it is symptomatic only. Usually you see in the context of some like cold fracture or something, patient develops some bony
Trivial fracture.
Yeah.
But the pain sets in to such a great intensity, even a air touch can give rise to such a severe pain, unbearable, for months together.
So there is swelling also, there is redness also, there is exquisite tenderness also. So again it is symptomatic treatment only. We give gabapentinoids, we give steroids. Yes sir, we can give. Usually the pain relief is achieved with the use of steroids and gabapentinoids.
Patient has no relief in them. Gabapentin and steroid also do a lot, 60 milligrams.
So we must consider alternate diagnosis also. Before considering it as CRPS.
I have not come across any treatment for this syndrome actually.
Sir, if you have that patient still with you in the second
I have the patient with me, but patient is not getting relief. All kind of treatment.
Just send it to him.
Oh, sure. Okay, last class.
Dr. Bhaskar,
yes, sir.
What about anything about burning feet syndrome? Is it just really B12 deficiency, or is it an impending neuropathy which is one should wait for or look for?
Sir, burning feet syndrome usually, classically it's a manifestation of a small fiber neuropathy. So small fiber neuropathy can have multiple etiologies, including alcohol, which is very common. It can be idiopathic. We have ruled out all the possibilities and still the pain is there.
One should always go in for a detailed evaluation.
B12 can be called diabetes. In fact, diabetes is the commonest cause of painful some heavy metals like thallium, they can cause it. So this is
very common, especially ladies, post-menopausal, they come for other symptoms.
So then we have to rule out, yes sir, we have to rule out non-organic etiologies also.
One more question to Dr. Manish Sarkar. Marijuana versus alcohol. They say marijuana is much safer than alcohol.
So both of them are harmful because both are substance of abuse. But I can always tell you, yes, both of them have the potential to cause not only dependence, which has physical morbidity, comorbid medical conditions.
Yes, with marijuana.
So marijuana, I can tell you, it is the most problematic. What I feel over the last 2 decades, what I have seen, the kind of psychosis, mood disorders, depression, anxiety, the kind of picture it produces, it is much problematic and tedious than it is what is created by alcohol, sir. So,
And the behavior alcohol is legal. Dr. Sarkar,
Hello.
can you come here? We want to capture you. Illegal. We want to capture
Just to clarify, it's an excellent comment, sir, you made. The burning feet syndrome. Historically, I have nothing to do with it. My father, Dr. C. Gopalan, who's a Padma Vibhushan, gave the Gopalan burning feet syndrome in India in the year 1945 or 1950. So this how many years ago it was? So it was B5 deficiency, vitamin B5 deficiency, and it was burning of the teeth, which he diagnosed. I had nothing to do with it, I was not even born then at that time. So it was called the Gopalan burning feet syndrome because of pantothenic acid deficiency vitamin B5. Just wanted to bring this point up. It was diagnosed in India many years ago, almost 50 or 60 years ago.
Dr. Sarath Gopalan's father was the Director General of ICMR. He was the founding president, chairman of National Institute of National Hyderabad. Dr. Sarath Gopalan at present is the president of Nutritional Society of India. He was my student in Sarkar Hospital.
Wonderful.
wonderful question. No. बात उसकी नहीं है, बात सिर्फ उसकी है कि मैं कितने बड़े-बड़े लोगों को पढ़ा चुका हूँ। मैं डॉक्टर सेन गुप्ता जो एमडी मेडिसिन FRCP डबल FRCP है, मैं उनको भी पढ़ा चुका हूँ।
मेरा क्वेश्चन अभी
डॉक्टर कांतरू है क्वेश्चन, एक मिनट, डॉक्टर कांतरू है क्वेश्चन।
Sir, I have learned about it that neuropathic pain you are giving the medicine to treat it, but main thing is the etiology of this thing. It can affect at the neuronal not at the nerve itself, then demyelination, axonal degeneration. So I am asking you, instead controlling the diabetes, peripheral neuropathy, all the hypertension, lipid normal of lipid levels. Similarly, it is a microvascular complication. My question is that are there some drugs, special drugs, to stop this process, reversal of the nerve and the processes, axons and you see,
So that
myelin.
The very good question. So that depends on etiology because we have different etiology. Like for example, let's go example by example. Like in B12 deficiency. Let's correct it.
Sir, मेरा क्वेश्चन है कि ये जैसे कि होता डायलिंग बिकॉज देयर कैन नॉट बी जनरेटेड नो ये किस लेवल पर हम रिवर्स कर सकते हैं इस प्रोसेस को
So by the use of drugs, we achieve the symptomatic control. And this is the one aspect. The most important aspect, we have to address the root cause also. That depends on the etiology. So etiology can be multiple. So depends on the etiology. What interventions should we take? As I said, lifestyle interventions are an integral part of management of neuropathy. And again, depends on the etiology. Like
there are not special drugs for this type of process.
Dr. Manu Saxena sir has a question.
The question is addressed to Dr. Manish. For pre-addiction alcohol, what is the duration and what is the cost per month to the patient? Because if we send someone, then we have to give a rough estimate. And what are the chances of success at the end of the specified duration?
Right, sir. I would say, sir, can you repeat your first question again?
Duration and cost.
What is the duration is?
What is the duration, the cost, and what are the chances of having a tangible result at the end of the specified duration?
Absolutely. So normally it varies from with the substance of the use. Normally in case of alcohol, and case to case also there is a variation. If there is a person having alcohol dependence where there is more complicated withdrawal like delirium tremens, it has 5% mortality, so understandably the intervention goes for a longer, even the detoxification also. But in a normal situation, typical alcohol de-addiction takes around roughly 3 weeks. So it is a combination of mainly medical management of benzodiazepines depending on the various other psychological symptoms which are there, antipsychotic or mood stabilizer medication. Thiamine deficiency is very common in alcohol, so you add those supplement and other vitamin supplementation. We put, normally it is seen that by 10 to 12 days, a lot of the people having alcohol dependence, they would have a significant amelioration of symptoms, their anxiety is better, their insomnia thing is solved to a great extent, the behavioral issues, aggression, violence, agitation is also in control, and they are amenable for one-to-one discussion. So there you start the psychosocial interventions. So little bit of cognitive behavioral therapy, group therapy in a structured manner. So that is also good. So normally it varies from person to person, but for alcohol 20 days, marijuana 15 to 20 days, opioids can sometimes take a little more time, say around 4 weeks to 6 weeks. Like heroin addiction is also very common. So it varies. So in terms of that is regarding the duration now, normally in our center, so we have different packages for various patients. So normally depending on the type of bed you opt for, so we have a single, double, 3-bed, 4-bedded facility. So the minimal cost, say for a month, say alcohol dependency is required, so it is around 1.5 to 2 months, including of everything, including boarding charges, everything.
Dr. Jitendra Saxena has a question.
Sir, excellent talk, Dr. Manish Sarkar, and I was really impressed by
place in Bijwasan, there also there is a de-addiction center, Dr. Raheja sir. And he also has got a very good center, sir. Sir, I have seen lot of patients who are under Raheja's rehab center. They come back to me. Sir, in my practice, I have not seen a single patient who is addicted to something. I'm not talking about alcohol, because there are various other substances. Iodex, codeine, of course, for X में मिल जाता था, ठीक है, and several others. Alcohol is just another thing. चिल्लम बहुत लोग लेते हैं वहाँ पे, because there are many several छोटे बाबाओं के आश्रम भी हैं वहाँ पे. तो चिल्लम में हो गया, मैरिजुआना लेते हैं, क्या लेते हैं, चरस, हेरोइन क्या है, we don't know. Sir, but my experience is these patients, they go to the addiction center, come back, go back, come, and then the cycle continues. Sir, in my experience, I have not seen a single patient who has been rehabilitated, goes back to work, becomes normal, accepted by the society. Doesn't happen, sir. Even if he stops taking this, he will have some other psychiatric problem. Maybe he ends up in schizophrenia or a maniac or a bipolar disorder. So that kind of thing is very, very common. That's my experience, because that place where I practice Bijwasan used to be sometimes back a hotbed of drug addicts. Not so much. Besides, these are substance abuse. Those who are taking intravenous 4-twin-phenargan, I have seen, there was a time, the truck drivers would come to me, sir, we have to drive the truck in the night, we want 4-twin-phenargan given to us in the vein. Sir, I said, I will never give this injection, you have to drive. कहते तू नहीं देगा, कोई और दे देगा, मुझे तो ये लगाना है. So many truck drivers, sir, you won't believe, they are driving with this intravenous injection, and that two intravenous 4-twin-phenargan together. So my lecture is about how do you ये ठीक तो होते नहीं सर, ये सबसे बड़ी बात है, ठीक ही नहीं होते.
उससे क्या हो जाएगा?
Frankly speaking, now addiction, relapse is a rule. Relapse is a rule. But having said so, you cannot just stop treating this patient. You need to try your best to improve the quality of life, to improve their overall productivity. At a larger point, the family dysfunctions, the occupational issues, if you don't treat them, with each day it deteriorates. So now we say that, like in rehab, so I am a rehab psychiatrist, so working mainly in the field of addiction, and we have a developed psychiatric disorders also. So we tell it to our patients, आपकी treatment जब आप यहाँ से बाहर जा रहे हो तब चालू. Rehab में तो आप protected environment है. You cannot go out. There are restrictions. There are privileges. But all kind of medical and psychosocial interventions are there. But your real life starts when you are outside. So integration of the family, integration of the well-wishers, integration of the treating team. So there you need to encourage them to come for follow-up, to remain in touch with the treating team, with the psychiatrist, psychologist, psychiatric social worker, addiction counselors. So sometimes it happens that a patient works very well with the psychologist. Chal koi baat nahi. Sir, मेरे को medicine नहीं खाना. Fine, you come for the therapy session. Some people say that I tell you the 12-step program. Fine, you come to the 12-step counselor and share your issue. So if there is an intensive intervention, it is a tailor-made for each and every patient. So if you identify the areas which can be potential reason for their relapse, you can accordingly put your intervention and try to minimize it. So it depends. Yes, sir.
Dr. Chon, just 2 minutes. Sir, what I wanted to say is कि कई बार ये लोग जब आते हैं ना एडिक्शन सेंटर में, वहाँ से सर ये क्रिमिनल्स बन के आते हैं. Because नहीं सर, मैं बताऊँ मैं इस एरिया से करता हूँ. That is not a 5-star area, sir. It's a Bijwasan is a village, and drug addiction is very common. So what they come across, साथ के लोग होते हैं, कोई कुछ होता है, कुछ होता है, बाद में वो ठीक तो होके आ गए सर, वो they indulge in all kinds of criminal activities.
I completely agree with you. सर देखिए थोड़ा सा तो ये भी डिपेंड करता है the crowd you are catering to. it also depends on the crowd you are catering to. So हमारा कहना है sir, medication, being a psychiatrist I tell you, I give only that much medication which is required. I am mainly into psychosocial intervention. So a lot of psychotherapy, cognitive behavioral therapy, integration of holistic approaches, anyway medication and
so self-help.
Yes, 12-step group.
And many a times the addiction of one substance gets substituted by others. Somebody is taking proximon, he gets addicted to codeine.
Secondary addiction.
Jitendra, what I would like to tell you is, you've been treating diabetes, type 2 diabetes for years.
Yes.
ठीक होती है कभी? कभी ठीक नहीं होती ना? आप मेटफॉर्मिन देते हो, सल्फोनाइल यूरिया देते हो, आप AGIs देते हो, आप बायोविटामिन देते हो, आप SCAP2 इनहिबिटर्स देते हो, आप इंसुलिन सेंसिटाइजर्स देते हो, फिर इंसुलिन देते हो और आजकल GLP-1 एनालॉग्स देते हो ना? ये सुनो, प्लीज कंसिडर ड्रग एडिक्शन और सब्सटेंस अब्यूज एज डायबिटीज। उम्मीद पे दुनिया कायम है दोस्त, उम्मीद पे दुनिया कायम है। कोशिश करते रहो।